Is this document on Joule?
Yes, so if you go to clinical resources,
Mm-hmm.
under that folder, you will see commonly given medications, common med list.
Okay.
I had a question about where do you find the medication summary sheet? I was looking for that earlier, but I didn't see it.
Medication summary sheet, where did you hear about that and what is it?
It's at the bottom of this document.
Oh. I'm not sure if I have that posted anymore. I can try and find that in my list of resources. All I did was make a table with this information on it, though. I can recreate that for you, Joanna.
It's okay, thank you. I was just wondering if it was like on Joule or not, but I can make my own.
Yeah. All right, so amlodipine, what medication is that? What class is that? It's a pene.
Calcium channel blocker.
Good. So what would we give this for?
Hypertension.
Good. This is an antihypertensive. Excellent. Side effects could include things like flushing, orthostatic hypotension. What would we want to check before we give it?
Vitals.
Heart rate and blood pressure.
Good. Heart rate and blood pressure. Some of your calcium channel blockers will affect just the peripheral system, and some will also affect heart rate. Amlodipine is not going to impact the heart rate, but it will impact the peripheral circulatory system in that it will dilate the arteries. Can also be used to treat preterm labor. Why might that be?
Prevents the contraction of the uterus.
Exactly. So calcium causes contraction. Remember those 3 C's? Not only does this medication impact the receptors at the arterioles, but it does so throughout the body. So if it's going to prevent contraction of not only the arterial system, but also an organ like the uterus, what other side effect do you think it might have on other things that need to contract?
Cramping.
So it could,
tract?
GI tract, yep. So it has implications for the GI tract as well. So if I'm giving amlodipine, I am checking vital signs. If I'm on the ICU, I'm getting my own set of vitals. If I'm on a med-surg floor, I want to look at one within the last hour. If it's out of range, I'm going to get my own and then determine whether or not I will give the medication. What would be a blood pressure that you would not give amlodipine? So what would be your lowest parameter? We generally say systolic of 100 is where we stop. But always take into consideration where your patient typically lives. If your patient came in to the ED in the 160s, 170s, and now they're at 100, that's probably not a good idea to give it, okay? Cardizem. You can tell me what cardizem is.
What's the generic name for that one?
Diltiazem.
Is it another calcium
It's a
channel
calcium
blocker?
channel blocker.
It is, and the reason I give you both of these at the top is because calcium channel blockers are a little bit unique in that they don't all end in the same suffix. So you'll have the penes, which there are a variety of, and you'll also have the ones that end in ZEM. Okay. Cardizem and diltiazem can also be used besides just for high blood pressure. They can also treat dysrhythmias. We can hang drips for them. So this type of a calcium channel blocker does have an effect on the heart itself. Again, since it's an antihypertensive, going to be checking both heart rate and vital signs. Be careful if your patient's on additional medications that could alter the heart rate. So we generally do not give multiple medications that have the ability to slow down the heart rate. Metoprolol.
Is it a beta blocker?
That's a beta blocker. You probably learned labetalol in Pathopharm. That was the prototype, I think, in Abrams. Remember your OLs. Metoprolol is probably given the most frequently. Although it is considered an antihypertensive, it is not a first-line treatment for blood pressure. Metoprolol is more frequently used for rate control. What does it do to the heart rate? Slows it down.
It decreases the force of contraction, right?
Yep, so contraction slows as well as the heart rate itself. Metoprolol usually has hold parameters, saying heart rate less than 60, hold it, blood pressure less than 100, hold it. Be very careful about holding metoprolol. Any beta blockers that are being given to your patient for rate control, you always want to talk to the provider first, because there are going to be many instances where you still give it for a heart rate of, say, 55, 56. Because if you stop beta blockers suddenly, what could happen to the heart rate? Reflex tachycardia. Yep. Oftentimes, these are given to patients that have AFib. We're trying to control that rate, and you would not want to hold it in that instance. You got to be really careful. Patients frequently report that if they take their metoprolol early in the morning, they get tired and fatigued. A lot of patients prefer to take the metoprolol after they've been up for an hour or two and are moving. Otherwise, if they do something sedentary after they've just given it, they find that they're tired and fatigued. Obviously, we'll take a heart rate and blood pressure beforehand.
Is that not something you can give on night shift, or they can take it home at night?
Metoprolol is usually given once a day or twice a day. The once a day is usually given at 10 in the morning or 10 in the evening in the hospital. Patients have their own regimen that they prefer, but I have had patients who report to me that they don't like to take it first thing in the morning. If they're going to be like sitting down for a while, they like to be up and moving. Otherwise, they get tired and fatigued. Lasix, we all know what that one is, right? That is a diuretic. What electrolytes am I looking at? Potassium, good. If your patient's on Lasix, what condition do they probably also have?
Some kidney failure.
They hopefully don't have kidney failure yet, but they probably have a heart condition. But we will want to look at bun and creatinine on a regular basis to make sure that we aren't making the kidneys unhappy. But if they have a heart condition, where should potassium be?
4.
Sure, 4 and above. Excellent. So we're going to be checking electrolytes on a regular basis. The patient's going to be losing, in addition to that, sodium and chloride. This is nice to know for now, but it'll be interesting to you if you ever work on a heart failure floor. We are always replenishing potassium, but when we give potassium, we're also giving chloride. So it comes in the form of potassium chloride. If your patient is on high doses of diuretics for, let's say, 5 to 7 days to reduce the edema and the fluid overload, your patients are susceptible to losing a large amount of chloride. When you lose chloride, you can become alkalotic. So there are many times when the providers are doing two things with the potassium chloride. They're replenishing potassium, but they're also replenishing the chloride that's being lost from the massive amounts of diuresing. Okay, so just keep that in mind. That's nice to know. That's not an exam question, but if you work on a heart floor, that'll be something you'll want to keep aware of. So you can have a metabolic alkalosis situation from aggressive diuresis with diuretics. So Lasix, I'll be checking blood pressure because it could drop it. However, just because you've got a low pressure doesn't mean you're going to stop giving Lasix. Let's picture our heart failure patient. What is my heart not able to do when I have heart failure?
Contract.
Contract effectively.
It's not going to squeeze very well, right? Lasix is going to reduce both preload and afterload, right? If I get rid of fluid in the vascular system, theoretically, we should be making it easier for the heart to pump, right? Because there'd be less fluid in the system. So if they're giving Lasix in the presence of a lower blood pressure, which I'll always contact the provider for, I have seen instances where the blood pressure actually goes up slightly because the heart can now push more easily against whatever fluid's still in the system, okay? So in a patient like you and I, we got a normal heart. If you give me Lasix and I dump a liter of urine, my blood pressure is going to go down. But patients who've got reduced ejection fractions, it may actually preserve their blood pressure or make it go up slightly. So don't always think it's going to tank them. Again, whenever you're holding or thinking about holding a medication that has implications for the blood pressure, always run it by the provider. Morphine.
Pain medication.
What kind of pain medication?
Opioid.
Opioid or narcotic, good. What am I concerned about when I give opioids or narcotics with my patient?
Respiratory
Respiratory rate.
Good, respiratory rate. Ideally speaking, how should you be counting the respiratory rate?
Over a minute?
Over a minute. And should the patient know?
No.
And when I used to work in the critical care environment, we were required to get a unstimulated respiratory rate. Not possible on a med-surg floor with a wooden door. But if I've got a glassed-in door, I could stand on the other side of the glass and watch my patient's chest rise and fall. That is ideally the way you would get a respiratory rate, because I'm not stimulating the patient. I want to know what they are at their level of rest. Does that make sense to everybody? Not always going to happen on lower levels of care, but try and get the respiratory rate at the patient's most relaxed state. Besides respiratory rate, what else am I concerned about with narcotics?
Bowels.
Constipation.
Stool softener.
Great, I heard bowel issues, constipation. If anybody is receiving pain medications round the clock, narcotics, they've got to have a stool regimen. It's not a matter of if they'll get constipated, it's when. I have taken care of patients who've had bowel obstructions from taking narcotics without a bowel regimen. Obviously, we're not giving these nearly as frequently as we used to in the hospital because we know, despite what the drug companies told us 10 years ago, they are addictive, even to patients who don't have a predisposition to addiction. Okay. So we've got morphine, strong painkiller, can give it orally, can give it IV. Oxycodone, also a narcotic pain reliever. This is an oral tablet that we give. Oftentimes, oxycodone can be combined with Tylenol. Probably heard that called Percocet before. Same considerations around morphine. So all of your narcotics and opioid pain medications are going to have the same nursing considerations. We're worried about CNS depression. We're worried about respirations, potential confusion. They're obviously a fall risk. Got to watch out for the constipation and make sure they're on a bowel regimen. Aspirin. Is it an anticoagulant or an antiplatelet?
Platelets.
Good, it's antiplatelet. I heard it once said many years ago that if aspirin were to be discovered today, the FDA would make it a prescription drug. That's how potent it is. It also has some fantastic off-label uses. Aspirin used to be the go-to for your grandmothers and great-grandmothers for arthritis, right? I had a grandfather who would just take it by the handful. Not exactly a good idea, but he did. He also had a stomach ulcer. Back in the day, we didn't even have buffered aspirin. So if you go to the drugstore now, what formulation of aspirin is the most common these days?
81.
81 milligrams. That's a baby aspirin, okay? We don't even give aspirin to kids anymore because of conditions like Rye syndrome. So you're going to find baby aspirin in the adult section of your pharmacy. what do we use aspirin for prophylactically?
For heart attack?
Good. So if anybody's had a heart attack before or is predisposed to having one, they're going to take at least 81 milligrams of aspirin every day. Trivial fact, 81 milligrams is the amount that the body can metabolize in a healthy liver in the first pass. So if you and I take 81 milligrams, by the time it has traveled through my liver, there is no systemic effect on the rest of my blood. So it only, as we say, antiplatelets the blood that's in the liver at that time. So 81 milligrams is not going to provide any amount of pain relief for your patients. It will simply cause the platelets that are present in the blood in the liver at that time to be less likely to adhere to each other. So if I take it every day, I am just slowly and steadily making sure that a portion of my blood is less likely to clot, mainly because it inhibits platelet aggregation. Now, your patient may also be on 325. If I see a patient's on 325 versus 81, I simply assume that the provider is thinking that they're a higher risk for a coronary event, so they put them on a higher dose. Okay? If your patient's having an active heart attack, do you swallow or chew it? Chew it. Okay? Active heart attacks, chew the aspirin, even if it tastes bad.
Why is that? Is it because it'll get in your system faster?
Yeah, it gets in the system faster, exactly.
Can you just crush it for them?
One more time.
Meaning is crushing the same idea, like just crush it and give it to them? Like what's the chew?
Either way,
Yeah, okay.
same principle, yep.
Would
Tylenol,
the
question,
sorry.
Lindsay.
Yeah, would it still be the same dose of like the 81 milligrams? Are they told to
No,
just
if you're
take
in the ED, you're going to get a 325. Good question. We need to prevent that clot from getting larger, so we'll go with 325. Tylenol, acetaminophen. What is it?
Relieves mild pain.
analgesic?
So it's an analgesic. It's also an antipyretic. I am not a huge fan of Tylenol in my house. Why? What is the big concern about Tylenol?
It's
Damages the
hepatotoxic.
liver.
It's hepatotoxic. I have cared for many patients that have liver failure from an overdose of Tylenol. You can overdose on Tylenol. If I'm taking Percocet, I will overdose on the Tylenol before I overdose on the oxycodone. So 4,000 milligrams a day is the max amount you can have in your patient with Tylenol. So anybody who's got liver dysfunction should be avoiding Tylenol. In addition, what should you not be doing recreationally on the weekends if you take Tylenol?
Drinking.
Drinking.
No drinking. So it's certainly not a good hangover cure. So if I've had a few instances where I've taken Tylenol for surgeries, I don't make sure alcohol's anywhere in my system for the next 24 hours. Okay. The nice thing about Tylenol is it is an analgesic. It also reduces fever, and it does not have any bleeding implications like NSAIDs do, which is why the hospitals prefer it. Less likely to cause bleeding. However, it is not an anti-inflammatory. It only reduces pain and temperature. Although your oral tablets that you find over the counter for Tylenol, most of us probably think Tylenol doesn't do much for pain. If it's given IV, it does very well for pain control. I've used it for post-op patients IV. It works really well. Tylenol also works very well in conjunction with other medications if given around the clock. Tylenol needs to be given on time. If you're using the extra strength, we usually do it every 8 hours. And if it's given round the clock in conjunction with narcotics, it does have a synergistic effect to reduce pain. So you will need less narcotics to treat the same level of pain. But you've got to give it on time. You can also give Tylenol in conjunction with NSAIDs. And they also have a synergistic effect to reduce pain. All right, that's my soapbox on Tylenol. Lovenox,
Anticoagulant.
anticoagulant. Usually
Isn't this
comes
usually
in
a shot?
yes, it'll be an injection. Usually comes in a preloaded syringe. It's got a weird safety. If you ever have to give it in clinical, make sure your instructor shows you how the safety works. Always going to check platelets before I give it. I may look at a baseline coags to make sure my patient's not super therapeutic. Lovenox can be given prophylactically to prevent DVTs. You can also give higher doses like 80 and 120 for patients who have got PEs or active DVTs. Patients can inject themselves at home. It is rather expensive because it's still a name brand. It's not generic yet. We like it because it can be given every 24 hours as opposed to every 8. Heparin's going to be every 8 hours, so your patient's going to get 3 injections versus 1. Heparin's nice because you can give it every hours, because if I have to give it every 8 hours, that means its therapeutic effects have left after that time. So from a intervention standpoint, if I'm caring for a patient in the hospital and they may be scheduled to have a tube line or drain removed, I don't want to give Lovenox that day because it's going to delay the removal of that tube. Okay. I'm going to stop there momentarily because I have some I's and O's needs. Does anybody else have any? So we will take a 3 or 4 minute break. Thought I could make it, but I can't. All right, I'm back. Story on Lovenox. I was a nurse on the surgical IMC at Maryland. We had a patient who had an epidural for pain control. And we didn't get a lot of spinal patients on the floor that we worked on, but he had an epidural, and patient was actually, I'm going to jump ahead of my story. I changed meds. My patient had Plavix. Anybody heard of Plavix before? It's down here farther, I believe. Do I have Plavix on here? I don't have Plavix on here. I probably should. What is Plavix generic name? It's a hard name to say.
Clopidogrel, or I don't know how to pronounce it.
Yep, clopidogrel. Plavix is like aspirin on steroids. So it's a massive antiplatelet drug. It also has an extremely long half-life. Patients who are on anticoagulants and antiplatelets, usually surgeons like to stop them before surgery because they're going to cause bleeding. I had a patient that was prescribed Plavix, had an epidural. I remember running it past my nurse practitioner because I'm like, he's got an epidural and he's getting Plavix. Is that okay? I got the okay from her, thank God, because the liability was now off me. A day later, the anesthesiologist came by to remove the epidural and looked through the MAR and found out that he got Plavix. We had to wait 5 additional days to take the epidural out because of the Plavix. It's got a half-life of about 5 to 7 days. You don't want to have a bleed in your spinal column, do you? So my long story short is when administering antiplatelets and anticoagulants, make sure you're very aware of what the plan is for your patient. On the surgical IMC, we also had a lot of Lovenox and chest tubes. If the patient was to have their chest tube removed that day, would you want to give Lovenox at 10 o'clock in the morning? Probably not. In the ideal circumstance, the provider would suspend the dose of Lovenox that day, but that did not always happen. So whenever I gave Lovenox to a patient with chest tube, I would always make a reach out to the provider, which thankfully they were on my floor. I'd say, hey, any chance this chest tube's coming out today? And I would ask that question before I went ahead and gave the Lovenox, okay? So Lovenox is a benefit to the patient because it's only given every 24 hours. That also creates a detriment to us providers in healthcare because we have to wait for that half-life to be gone before we can do an intervention that may cause bleeding, okay? So that's my anticoagulant, antiplatelet story. Heparin, cheap as dirt. We give it all the time. It's been around forever. Give it 3 times a day. If your patient's got renal dysfunction, that's the preferred method for prophylactic treatment of DVTs. It'll be a sub-Q injection. We can also give it IV via a drip, in which case we're going to be checking APTT every 8 hours, and we'll be titrating the dose based upon those values. Can be used to prevent DVTs, treat active DVTs, for PEs, for strokes, for heart attacks. So anybody who's got a clotting disorder or an active clot, we can put them on a heparin drip. Dilaudid hydromorphone, what is that?
A pain medication.
Pain medication, good. And it's 10 times stronger than morphine. Milligram per milligram is 10 times stronger. So if I'm giving 1 milligram of Dilaudid, it's like giving 10 milligrams of morphine. I don't give it nearly as often as I did 5 years ago because of our situation, but powerful, effective narcotic. Same nursing considerations as above. Aspart, insulin, what is that? We talked about that in the Kahoot.
Short-acting insulin?
Short-acting insulin, usually given before breakfast, lunch, and dinner, and sometimes before bed. We will figure out what the blood glucose is prior to the meal. So it's a fasting blood glucose, and we will give the amount of aspart that our sliding scale tells us to give. Lantus is a long-acting insulin. I always remember L for long. This is usually given at morning or evening. It's got a 24-hour duration. There is no peak or trough. It's just a steady release of insulin across a 24-hour period. When I have Lantus on board, if I'm giving a report, I always like to tell the oncoming nurse that I gave Lantus. Why do you think that might have implications for the following 12 hours?
Blood sugar's gonna go down.
Make sure they eat.
It's got a potential to go down. So what I think about is if my patient, so Lantus is prescribed by the provider or the endocrinologist based upon a certain caloric intake each day. If something happens during the day or night that would alter that caloric intake, they may have had too much Lantus given. So if my patient starts to have emesis or vomiting in the middle of the night, that may cause my patient's blood sugar to drop because they've still got Lantus on board. If my patient's tube feed and the J tube becomes clogged and they can't get their tube feed, do you think that might make for a hypoglycemic event? Okay, so that's why it's important to know if your patient's gotten long-acting insulin. And I don't make my oncoming nurse look back in the MAR 12 hours ago. I tell my oncoming nurse, hey, I gave X number of units of Lantus today. They're going to be on board for you tonight. Okay. Important information.
Dr.
Albuterol.
Parker?
Sorry, go ahead.
I just wanted to clarify with the short acting and the long acting. So the long acting is usually given in the morning or evening, but the short acting is given with meals.
It's usually given breakfast, lunch, dinner, and sometimes before bed if still needed.
Okay.
Yep. So the aspart treats the peaks, and the Lantus kind of evens things out. We'll talk a lot more about these when we get to our metabolism lecture later this semester.
Okay.
But I want you to know about these because you're going to see them on your patient's MARS. You will not have many chances as a clinical student to give insulin, mainly because you also need to be involved in the glucose meters, which the glucometer police in the hospital are pretty strict. They don't allow nursing students to use them much because of the implications around patient safety. As you can imagine, you go and get a blood sugar and it's 60. If you don't respond to that quickly, you're going to have a serious implications on your hands. So students don't get a chance. But if you ever get a chance to give insulin with your instructor, certainly take advantage of that. But we don't get as many opportunities as I'd like. Albuterol.
I said that we can't.
One more time.
I just remember because we were discussing yesterday and she said we can't.
Yeah. It's kind of unit-based, but it's difficult. It's also a two-nurse check some places as well, which makes it really difficult for your instructors. Albuterol.
Beta blocker.
It's
Isn't it a steroid?
a beta agonist.
Beta?
Yep. Albuterol is a respiratory drug. We use it to dilate the bronchioles. And since it's a beta agonist, what could it do to your heart rate?
Increase it.
Good. Doesn't mean I won't give it if the heart rate's up. No, but I just want to be cognizant of it. Okay. Can make your patient feel jittery, anxious, nervous, but it also helps them breathe. So typically used as a rescue drug. Can be given via a metered dose inhaler. It could also be given via neb. Lisinopril, you've heard about this one a lot, haven't you? ACE inhibitor used for high blood pressure, used for heart failure. You always want to be mindful of first dose hypotension and always looking for signs of anaphylaxis because the angioedema can not only happen within the first few doses, but it can happen 6 months later. Often causes that dry cough, which makes patients not tolerate it. Protonics.
Proton pump inhibitor
Good. Why do we give it in the hospital a lot?
Prevent ulcer.
to prevent ulcer.
Good. So just because my patient doesn't have GERD doesn't mean we're not going to give protonics. So oftentimes my patient will say, why am I getting this medication? I don't have acid reflux or anything. And you can say it's to prevent the formation of ulcers in the hospital. Can be given orally, can also be given IV. Lowers the gastric pH substantially. I should say it lowers the acid, which raises the pH. Got to be careful how I use those terms. So pH will be above 4 generally if patients are on it. Because it reduces the acidity of the gastric secretions, It also predisposes your patients to C. diff. But we kind of give it out like candy in the surgical world to prevent those ulcers. Docosate.
Stool softener.
Good. And it's just a stool softener. It's not going to promote a lot of cramping or diarrhea. It's just going to help to soften the stool. We'll give this to any of our patients who've had bowel surgeries or on pain medications like narcotics.
And I also learned yesterday, in the system at Maryland, they have like, when you're looking up drugs, it'll tell you like it's like a drug book on their computer you can use.
Yep.
And I was looking up the meds for the day, and Docosate was one of them, and it has it classed as a laxative. So be careful.
Yeah, I don't
Right,
like that. I
because
don't like that drug manual. It's actually not a laxative.
right, I know. And we went into the Pyxis, and Jackie asked me what was Docosate, and because it had said laxative, I said laxative, and she was like, actually, it's not. So then we went over it, but you just have to kind of be careful for that drug book. It also has aspirin as an analgesic primarily. So like, you got to just kind of know those things, I guess.
Yeah, the drug manual at Maryland through Epic is fine from everything else, the classes that it chooses to call things I don't always agree with. So I'd like you to think of Docosate as a stool softener. The true definition of a laxative is something that induces peristalsis. Prednisone. We could write a page on this one, couldn't we?
Anti-inflammatory steroid.
Anti-inflammatory steroid, good. So it is a corticosteroid, reduces inflammation. However, it also reduces the immune response. What's it do to blood sugar?
It can elevate it.
Yes, it's going to alter the way I metabolize sugar. Patients who are on high-dose steroids may get their finger stick taken and have a sliding scale for insulin while they're in the hospital. So I've had many COPD patients that are not diabetic ask me, why am I getting insulin and getting my finger stick checked breakfast, lunch, and dinner? I'm like, it's because you're on high-dose steroids. Doesn't mean it's permanent. It's just while they're on those high doses. If they're on a high dose for a long period of time, what do we got to be careful of as we think about stopping it?
Taper the dose.
Taper the dose, good. So you can put somebody in adrenal crisis if we stop it too quickly. Also causes water retention and weight gain. So think about systemic side effects of prednisone. There's lots of them. This is one of the medications. Prednisone is usually the oral form. You can also give methylprednisone, I believe. I'm trying to think of the way it comes in the vials. And methotrexate. There's a bunch of different steroids that we use. Some of these steroids are now being used to treat our ICU patients with COVID, and we're having good results with it. Zosyn. Anybody heard of this one? Antibiotic.
Penicillin, I guess.
It is a penicillin derivative, so be careful if your patient's got a penicillin allergy, you shouldn't take this one. Zosyn is used a lot in the hospital, especially for our surgical patients. I used to hang it on a regular basis. Just want you to be aware of it. It's an IV formulation. Vancomycin.
Antibiotic.
Antibiotic.
And what do you always think of? What's the first thing you think about with vancomycin?
MRSA.
Okay, yep, we can use it for MRSA.
It's renal toxic.
Excellent, renal toxic. I like you to say that. We got to check levels. We need a peak and a trough on this one. We're usually, most of the time when I've been asked to get levels, we get a trough. They'll ask for a serum value right before the next dose is due. And if you're in doubt, call your pharmacist as to whether or not they want you to hang that dose or hold it until they get the result back. We usually do it every third dose. We usually like the levels to be between 10 and 20. I do not remember the units of measure, but it's between 10 and 20. If they're high, they'll sometimes hold a dose and adjust the next one down. But this is a medication that we will do what we call renal dosing. So we will check these troughs and dose it for the next 3 based upon where that value was.
Yesterday, one of the nurses on the unit, she actually was hanging vancomycin, and she showed us how she calls the pharmacy to make sure because she was running it with another drug, and she had to call to make sure that they could be run together.
Good.
And she also said you never run it with, I think it was potassium.
You'll have a drug manual on your Epic and Power Chart, wherever you are, that will allow you to check. It's called Micromedics. You can check IV compatibilities. My first 2 year nurses, all I did was plug stuff in there to see what's compatible with what. I still look it up occasionally when I have to run multiple drugs through one IV, which I never like, but it'll give you a green light if they're compatible. If it's cautious, it gives you orange, and it gives you red if it's not. I don't hang anything unless it's green. Well, it's a green light to go, but that's always something you want to be aware of, is what can run together. Also with vancomycin, it is a vesicant in that it could really cause a lot of phlebitis. So I liked my IV to be exquisite. I'm going to flush that thing a few times before I decide to run vancomycin through it. If it's not secure and in really well, I'm going to ask for a new IV. And while it's running, I'm going to be asking my patient how the vein feels as it runs through and checking that patency. If you don't think your IV is that patent, do not hang the vancomycin. Okay. Having had most of my early career in critical care, I always liked running it through a central line better than I do a peripheral. Now that I'm on med surg floors all the time, we don't have central lines, we're just running through peripherals, but I'm always cautious and a tinge anxious when I run it through a peripheral, especially if it's not in a great location. So just be mindful of that. Hydralazine.
Vasodilator?
Good. It's a rather potent vasodilator, and it is specific to the arterioles in that it only works on the smaller arteries. So it has a very good ability to reduce peripheral vascular resistance. Works really well to treat blood pressure. Interestingly enough, African Americans that are resistant to other antihypertensive drugs usually have a very good response with hydralazine to reduce their blood pressure. Be careful of reflex tachycardia. If I were to suddenly drop each one of your blood pressures, what would your heart rate want to do? It's going to want to go up. So if I'm giving hydralazine, especially IV, to a patient who's never gotten it before, to treat, significantly elevated blood pressure, I want to be careful that their heart rate's not already in the 90s or 100s, because it's going to go up. Now, if my patient's already on a beta blocker, it's not going to happen, okay, because they've got that block. But always be mindful of the heart rate when you give hydralazine. It can be given orally. Orally, it's usually given every 8 hours. Anybody who's ever taken antibiotics and compliance with meds knows that it's much easier to take meds that are due once or twice a day. You start throwing that third dose in there, and we oftentimes forget that middle dose. So hydralazine is a medication that, if given orally, it's only given every 8 hours. So it's going to be given somewhere in the afternoon, which means your patient, when they're at home, is frequently going to miss that dose, which is unfortunate. So just be mindful of that with compliance issues. And that's my soapbox on the commonly given meds. Any questions? All blood pressure drugs, you should check what before you give it?
Blood pressure.
And heart rate. Good. If you're looking at your vital signs and you see a set of vitals that were not taken by you and they look like they're out of the patient's baseline, what should you as a nurse do?
Take another
Take a
set.
new set.
Vitals again.
Take another set. There are so many variables that go into a blood pressure. So you don't know if that patient just walked from the bedside commode to the toilet back to bed. You don't know if the patient was lying on their side, were their legs crossed, were they laying, sitting, standing. There's so many things that could impact that blood pressure. So if in doubt, well, when you give your meds in the morning, it doesn't hurt to get another set. Okay? And if you're working at a critical care, you're going to be getting your own set anyways, because I don't give blood pressure medications unless the vital signs are within the last 15 minutes. And thankfully, when you're in the ICU, you just push a button above there and you got all your stuff. Super easy. Okay. Any questions, thoughts, concerns? Okay. Do we want a short break before we dive into perfusion? No, we're okay. All right. We'll do about a half hour and then we'll take another break. How's that sound? Okay. All right. Well, let's dive in. All right, everybody see my screen? Last night, late when I got home from school, I went back and adapted all of the new charts, tables, and pages that I wanted you to reference within here. So if you've downloaded it prior to last night, you probably got the old version. If you download it again from Jewel, you'll see the new one, which I have here. All right, so within this course, this is what we will cover over the next 2 weeks. We have assessment of perfusion. We'll go over some basic rhythms and conduction. We'll be strongly focusing in on normal sinus rhythm, sinus tach, sinus brady, as well as atrial dysrhythmias. You'll cover all of the ventricular dysrhythmias, mostly in adult health too. We'll cover CAD and MIs, vascular disorders, such as hypertension. We'll touch on PAD versus PVD and also DVT and PE, and then we'll wrap up with CHF, all of which you should have had in pathopharmacology, right? So some of this should be a review, but we're going to focus more on the nursing care over the next 2 weeks than we will the actual disease process. Short review, we've got two systems within our cardiovascular system. We've got the systemic circulation and the pulmonary system. Which one's low pressure?
Pulmonary.
The pulmonary system should be a low pressure system, and that helps to facilitate gas exchange, whereas the high pressure system helps to deliver oxygenation and the nutrients that we need, as well as distributing back the waste products from our cells. Oops, went too fast. I just said those things. Let's see. What does MAP mean to you all?
Mean arterial pressure.
Good. And which number is multiplied times 2? The systolic or the diastolic?
Diastolic.
Good. For most of us, when we're at rest and our heart's a normal rate, we're going to be in diastole longer than we're in systole. MAPs are very important when we're talking about critical care nursing. What is the lowest MAP that our kidneys will tolerate? Anybody know?
65.
Good, 65. That's the bare minimum. Once you start going below 65, kidneys get unhappy. If you've got even about a 10 to 15 minute event below 65, your patient's kidney numbers may reflect at the following labs. Changes with age. As we age, we start to develop calcification. Has anybody heard of calcification before in your arteries? Interesting side note on calcification as we age. I read an article about nutrition and our cardiac diet that was, remember the low fat craze we had in the 80s and 90s? Like no fat, right? And all the snack wells came out. Everybody was eating sugar like crazy, but no fat. Everything was low fat, no fat. Interestingly enough, you need a certain amount of fat in your diet to allow the calcium to be absorbed. So calcium needs fat to be absorbed into your cells in your body. During this time where people were eating virtually no fat, we noticed we had an increase in calcification amongst our population. So although this cardiac diet we came out with in the 90s supposedly was supposed to help cardiovascular health, it actually had some detriments. Okay. One, it instituted more calcification of the arteries, and two, what happened to our patients' blood sugars during that time?
Drop.
We got more diabetes than ever during that time. So don't forget that fat is a satiety food. So it makes you feel full when you eat fat. So I've always said you're better off having a cup of ice cream than you are having an entire tub of no-fat ice cream, okay? So calcification happens with age, although we know it's somewhat dietary related now. As we age, the conduction within our heart starts to change. Conduction becomes delayed between the SA node, the AV node. We're more likely to experience dysrhythmias, more sensitive to cardio, things like caffeine, things like the drugs that we have, foods and things that can excite the heart are more sensitive as we age. Also, over time, because of usually hypertension, the left ventricle becomes more stiff and fibrotic, which means not only does it not squeeze as well, but it doesn't what as well. We need our heart to squeeze, but we also need it to
Relax.
relax so it can do what? What's it got to be full of?
Blood.
Blood.
Good. We want it to fill. So as you know, balloons over time start to get overstretched and stiff sometimes. So think about your heart when it's 80 versus 20. Not only will it not squeeze as well, but it won't relax enough to allow enough blood to get in there. So that can reduce cardiac output. As we age, our arteries also become stiffer. If you were to listen to the Korsakoff sounds on an average 25-year-old versus a 70-year-old, you will notice a difference in the sound. The Korsakoff sounds on an older person are going to sound more like a clap than a thud because the arteries are not as elastic to each pulsation of the heart. In addition to that, the aorta can become particularly calcified. When I'm working on a cardiovascular floor, patients will have to have a CT scan of the heart and the chest, and the surgeons are looking to see how calcified the aorta is. If your patient's going to go in for a bypass surgery, during that time, you're going to be put on a heart-lung machine, and they're going to have to clamp off your aorta. In order to clamp that off, they have to put a thick clamp across the top of your aorta. If you've got lots of calcium right there, they can't clip off because they could cause a disruption in that calcium, which could then free flow up into the brain and cause a stroke. So I have had patients that are no longer a candidate for a CABG because their aorta is too calcified. Baroreceptors, what does that term mean to you?
Receptors that determine the pressure in your arteries.
Exactly. So when you and I stood up to go to the bathroom a few minutes ago, what do you think our baroreceptors did for us?
Prevented orthostatic hypertension or
Excellent.
hypotension.
Yeah. So they recognized we had different pressures within our vascular system and kicked up the heart rate and squeezed and constricted the appropriate blood vessels to keep my brain perfused. As we age, those baroreceptors are slower, which is why you want to be mindful about getting your patients up quickly from the bed to make sure they have a chance to equalize. Okay, so a little bit slower response from the baroreceptors. That sympathetic and parasympathetic systems start to become a little bit delayed. All right, so we're going to work through the concept of perfusion here for a minute. And before we jump into the next section, I'd like to kind of make some connections. So a lot of our concepts that we think about physiologically are very strongly interrelated with perfusion. How is mobility impacted by perfusion? So if I'm mobile, what does it do to my perfusion?
Increases
Increases
circulation.
Good, it increases circulation. If I don't have good perfusion, what does it do to my mobility? Decreases it. Exactly. So if I've got activity intolerance because of poor cardiac output, I'm not going to be as mobile as I should be, which makes a big predicament for our patients with heart conditions. they have to be careful and have a nice balance between activity and inactivity. Perfusion and gas exchange, we know they're directly related. I have to perfuse my lung field so that I can have gas exchange at the level of the alveoli. In order to have good functioning GI tract, I've got to perfuse the gut. For adequate cognition, I need to have adequate blood flow to the brain. How is perfusion and pain related?
Lack of perfusion to an area can cause pain.
Yes. So if I have a heart attack, I'm essentially experiencing pain in my myocardium because I'm getting an inadequate amount of oxygen to it. Anybody ever have pain, hopefully not here, pain in their feet because they have decreased sensation? I'm sure if you cross your legs too long, you probably get pins and needles in your feet, right? That's poor circulation. That could be due to just positional, or it could be due to disease. So if I've got atherosclerosis in my lower extremities, I could have something called intermittent claudication, which we'll talk later on this class or next class about. So it's like,
Dr. Walker,
yeah.
when you know sensation of like tingling in our hands or in our feet, is that, you know, the same thing as having like improper like circulation when we get that tingling in our hands and our feet?
It can be both circulation and also cutting off or putting pressure on the nerves.
I have a random question. So when I was like pregnant, I'd like wake up in the middle of the night with like death pain on my calves.
Okay.
Yes. And like now I'm thinking, would it be because maybe I had no idea what it was. Now I'm thinking maybe it was like lack of blood flow or something.
There are some conditions where if you lay in the wrong position when you're in the last trimester of pregnancy, the baby can occlude the circulation to the lower extremities. Yeah. I forget what side it is, but I think in the last trimester, you're not supposed to lay on one side because it can cut off circulation.
Your left
And I
side.
want you to lay on the right side, so you
Oh,
lay on
right.
the left side. Yeah, well, they don't want you on the right side, so you lay on your left side.
Right.
Gotcha. So pain, obviously perfusion, we're having many infarcts. Perfusion and clotting are related both ways. If I don't have good perfusion, I'm more likely to clot. And if I've got a clot, then I can't perfuse something. Inflammation, how does inflammation impact perfusion? If my patient is
They can
septic.
squeeze your vessels, right? So
Say
like
that-
if
say the
you're
beginning, Lindsay.
inflamed, I said if you're inflamed, wouldn't it possibly squeeze your vessels? Or if they're like super dilated, then it does the opposite. But like if like you're really swollen, it can like block the perfusion, I think too.
Good.
It's
So there's
not
two
good.
things that can impact. So from an intravascular standpoint, if I've got systemic inflammation, what happens to my fenestrations in my arteries and veins? Are they closed or are they open?
You have increased permeability.
Yeah, increased permeability, which means fluid's going to leak out, right? So then I don't have enough fluid in my vascular compartment, which can decrease perfusion. And as Lindsay said, there's also a point where there's so much pressure from the interstitial swelling that it can put pressure on the ability to perfuse. So it's two factors there. And we'll talk about patient education throughout. So I want you to just, this is a way to think through how multiple things can impact perfusion in both directions. I'm not going to break you out into groups right now, but let's go through this together. What are some neurological abnormalities that could occur because of poor perfusion?
Confused, lethargic.
What was that?
Confused, lethargic.
Good. So change in mental status, confusion.
Stroke.
Good. You can have a stroke. Excellent.
Can it be nerve death as well?
Yeah, does neuropathy count?
Neuropathy definitely counts. That's related to perfusion.
What about a DVT or like a venous insufficiency?
DVT, I'd probably stick with a cardiovascular side.
Cardio.
But it certainly is a symptom. Yep.
What about vision loss?
Yes, vision loss. Good. We know that hypertension can cause damage to the eyes.
rising BUN and creatinine.
Rising bun and creatinine. Are you trying to connect that through a neuro because of the change of mental status from the uremia? Is that where you're going?
Exactly.
Bun and creatinine, I would probably stick under GU. But as you know, if I've got an elevated bun, uric acid and uremia can cause changes in mental status just because of the toxins that are building up in the bloodstream. When I think of neuro, I also sometimes throw in musculoskeletal. So you could have impaired mobility due to decreased perfusion. Oxygenation-wise, what are some changes? What might you see? And here,
Decreased cap refill.
I'll put that under cardiovascular.
Okay.
Cyanosis.
I'd still put that under cardiovascular. You could be either way. I'm not going to nitpick, but I will.
Acidosis, alkalosis.
Right, shortness of breath.
What was that, Kyle?
Acidosis, alkalosis.
Yeah, we could be acidotic. That would probably be more of a metabolic condition. What am I going to hear? Think about lung sounds.
Crackles. Lung sounds.
Crackles.
Could have crackles. Excellent. And where would I probably hear those first?
Lower lungs.
Good. Lower lobes, crackles. Excellent. So I got some backup.
Shortness of breath.
Good. Shortness of breath. What's my respiratory rate going to be like?
Probably fast.
Good. Increased respiratory rate. Excellent. What's the term for a patient who's short of breath in certain positions?
Orthopnea.
Good. They might have orthopnea. Has anybody heard of 3-pillow orthopnea before? So I can't sleep without 3 pillows. That's a patient who can't lie flat. Think about your respiratory assessment. What else might you see?
Maybe increased work of breathing.
Good. Excellent. Using those accessory muscles. All right, the easiest category, cardiovascular. What are you going to see? Decreased perfusion.
Cap refill decrease.
Decreased cap refill. Good. What? How about my pulses? What will they be like?
Ready. Weakened, ready. Bounding.
It could be 2 things. If I've got hypertension, they may be bounding. But if I've got heart failure, they may be ready or absent. Good. What kind of heart sounds might you hear? How about murmurs, rubs, and gallops? S3, S4. What else? How about up here?
JVD.
You could have some JVD. Excellent. What might you assess in the lower extremities?
Edema.
Excellent. Heart rate could be up or down. Blood pressure could be up or down. GI-wise, what might your patient have more commonly if they've got poor perfusion?
UTIs, maybe?
Well, think GI first.
Oh.
Constipation.
Good. Constipation. Decreased appetite. Nausea. Late signs would be vomiting. What's their belly going to be like?
Distended.
Could be a little distended. And eventually with heart failure, you can have enlargement of the organs in the abdominal cavity, especially the liver. Back to GU. Poor perfusion to the kidneys will result in
Urinary retention.
not directly urinary retention. That would be a bladder problem.
Acute kidney injury.
We could have some acute kidney injury, we could have chronic kidney disease, and we could have, what's the urine output going to be like? Down. Or when the kidneys don't get enough fluid to them, they're going to hold on to things, which means they're not going to make as much urine. Good. Skin-wise. Somebody had said cyanosis early on. Could have cyanotic. What about wounds? What are wounds going to do when there's poor perfusion?
Decreased wound healing.
Good. Decreased wound healing.
Necrotic tissue.
Could have necrotic tissue. Yep, you've probably had, I've had patients, and you probably have heard these stories before. You take their socks off and their toes in the sock. It's like it's a necrotic toe that just kind of crumbles to pieces.
Would you have some tenting?
Yes, so you could look at the skin to see whether they're dehydrated or not. That's a good one. So temperature of the skin.
It would be
oftentimes cool. My heart failure patients, if I put the back of my hands on their legs are going to be cool. That's a sign of poor perfusion. What labs and diagnostics will I look at? And think simple first. What are the two labs you're going to look at every day in the hospital? Everybody gets them regardless of whether they need them, unfortunately.
Hemoglobin, hematocrit.
So think about what panel that's going to be from. So if I wanted to order those labs, I would order it under a BNP and a CBC. If I'm a hospitalized patient these days, I get one every day whether I need it or not. So BNP and CBC, why am I looking at, what am I looking at specifically there?
Electrolytes.
Good, electrolytes. Kidney function. I want to check for anemia possibly. I'll look at the H and H. What other labs done?
CO2.
We could look at CO2, excellent.
And blood gases. ABG.
We could look at ABGs, yes. I'm going to make you all hold for a minute. Sorry about that. 5-year-old emergency. Where were we? Oh, labs and diagnostics. How about labs that are specific to MIs? Anybody have any MI labs they know of?
Troponin.
Good, troponins. Labs for CHF.
Potassium.
Good.
Well, that would be in the BNP.
Yep. How about something called a BNP? Binatrial peptides. Measure the stretch of the heart. I could go on diagnostics forever. We'll talk about those throughout. So echoes, EKGs.
Would pulse ox be considered one as well?
Yeah, that's a good one. Definitely. All right, so as you can see, perfusion impacts every body system significantly, right? Whenever someone's got a perfusion problem, you're going to have a pretty solid assessment here, looking at a lot of different things.
Dr. Walker, what is that other box supposed to be on the side of signs and symptoms? It just says S.
It's an empty box.
Okay.
The only reason I have the S there is to keep the box open with a letter so I can type something if I need to. That's all, but there's nothing there.
Okay.
All right, so a short review. Cardiac conduction. In order for the conduction to work, we have to have connections between the SA node, the AV node, and the Purkinje fibers. There's a delay in the conduction between there, which allows the heart to fill from the bottom and squeeze from the bottom up. The atrial activity and the ventricular activity have to communicate together to have an effective filling and squeezing of the heart. P, Q, R, S, and T, I need you guys to know those intervals. On your past class, you went through that activity. Hopefully this semester, while you're in clinical, you may have the chance to look at some strips. For those of you on C6, I know you'll have lots of strips to look at. Weinberg 5 will have some patients on telemetry. And how about Bayview? Was anybody on tele?
I think they said there was only like one person on tele when we were there.
Okay. Whenever there's somebody on tele, ask Liz at some point during the day, hey, let's look at a strip together and let's try and measure the intervals, okay? All of the instructors will be able to do that. Here's what the waves are correlated with. I'm not going to lecture on this. You had this in pathoform. You'll need to review this. I will be most likely giving you strips that you'll have to identify on the exams. I need you to be able to identify normal sinus, sinus arrhythmia, and sinus tach. I've got a self-study module within the perfusion content on Joule that I'll need you to go through. You need to be able to measure these intervals, know how many QRS complexes are in a 6-second strip so you can calculate the rate. I will always give you a 6-second strip. I'm not going to throw you off, okay? So if I've got 6 QRS complexes in a 6-second strip, what is the rate?
60.
Good. All you gotta do is multiply it times 10. All right, sinus Brady, you know that's going to be less than 60.
Professor Walker, just a quick question on the previous slide. For the sinus arrhythmia, would the rate then be 50?
1, 2, 3, 4, 5. Yes, and you can see we've got a pause here. I will not give you this rhythm to do on an exam.
Okay.
So I want you to know normal sinus. I want you to know sinus tach. I'd like you to know sinus Brady. This is more of an adult health strip, the PACs and the PSVTs. You definitely need to know the difference between A-flutter and AFib. As you look at these, if I look at QRSs first, are the QRSs spaced evenly up here?
Yes.
They are. Are they spaced evenly on this strip?
Nope.
So that is your biggest difference between AFib and A-flutter. Both of them have conditions in which the atria is kind of quivering as opposed to squeezing. A-flutter usually looks like the sawtooth wave, but the QRSs are regular. So conduction messages are still getting down to the ventricles and they're still squeezing on a regular interval. In AFib, the communication between the atria and the ventricles is no longer as effective. We're starting to get random squeezes from the ventricles, which show as these irregular intervals on the QRSs. If someone's in AFib and they're not on a monitor, what's their pulse going to feel like?
We won't be able to all over the place.
It's going to be inconsistent and irregular. Good.
And it's very hard to get a blood pressure on those patients.
Yes, it is. Yep. So AFib, a regular heart rate, A-flutter, a regular heart rate. Both of them have reduced cardiac output though. We've lost about 25% of the fill because the atria are not squeezing the rest of the blood into the ventricles. Okay. AFib is associated with a higher risk of clots, especially in the heart. Why is that?
The blood pools. It's not really moving as it should.
Excellent, good. So they're more likely to develop a clot in the atrium. Those clots usually end up as being strokes because they usually most often form in the left ventricle. Here's an example of a PVC. What is a PVC often termed? What do we call that in the regular public? So you probably, somebody here has probably had PVCs before. Anybody heard about heart
palpitations?
Yeah, palpitations. Yeah. About 3 years ago in the middle of my PhD program, I was consuming too much caffeine, not sleeping enough, and I was all stressed out, and I was sitting at my desk at Notre Dame, and I got a serious run of PVCs that went on for about a day. And I could not tell if I was in AFib or if I was just having PVCs. I really thought it was probably just PVCs, so I presented to the ED and got a whole cardiac workup and had to wear a Holter monitor for a few days, and everything was fine when I cut out caffeine and started taking magnesium. But long story short, watch out for stress and caffeine because they can institute PVCs. My brother-in-law had a huge caffeine problem. He's a recovering alcoholic, and instead of just not drinking, he decided to drink tons of caffeine. He would drink a pot of coffee a day. He got himself into AFib. So he was on anticoagulants for about 3 months. He self-converted back to sinus rhythm, thankfully, but it was a combination of way too much caffeine and stress. So these energy drinks that we all have out there right now have a lot of detrimental effects for heart rates. They can actually cause ventricular dysrhythmias if you drink too much caffeine too quickly, so be careful. So if you see me drinking coffee, it's usually decaf. While we're on PVCs, what does a PVC do to cardiac output? Does it reduce cardiac output or increase it?
It reduces it?
It reduces it, and why?
Because ventricles don't squeeze all the way and not pushing the blood.
They do squeeze all the way, but if it's, think about this, if it's a premature ventricular contraction.
So is it not able to fill back up all the way?
Exactly, so my heart has not been done filling. My ventricle decided to squeeze before all the blood was there. So if I get 1 or 2 PVCs every minute, not a big deal. But if you see on your strip, your patient had 3 or 4 in a row, first thing I'm going to be doing is going in saying, hey, did you feel that? How do you feel? What's your mentation like? If they continue, I want to get a blood pressure. They can be dangerous when they come at a rapid rate and when they come in succession. They will significantly reduce cardiac output if they're sustained. Because again, we're squeezing at a time in which the ventricle is not yet completed filling. So we're reducing cardiac output. All right, that's a strip. So AFib, common dysrhythmia in the US. There are lots of people walking the earth in AFib. Hopefully they're on something to control the rate and on an anticoagulant because they're more likely to have the strokes. The atria ends up squeezing in a disorganized manner. They don't have any effective P waves, which means that you're not going to get the fill from the top of the heart. So as I mentioned, loss of atrial kick, a regular pulse, could be due to systemic hypertension, older adults, coronary artery disease, a couple of others that I don't have on here. Anybody who's, I'd say middle-aged and older who has surgery is prone to AFib. They have a risk for it because of the fluid fluctuations that occur in surgery. Patients who've had thoracic surgeries, anytime we manipulate in and around the heart, the atria are very sensitive and they can have post-op AFib. Obviously, patients with heart failure are very prone to it because the atria get stretched out due to the increased preload. And as I mentioned, they're at high risk for embolic events because of the clot factors. Here is an example of AFib on a 6-second strip. Each of these arrows correlates with 3 seconds. We can see here if I were to count the rate, you got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And I would probably not count this one here, the 11th one, because it's off the strip. So we got 10 in a 6-second period. Heart rate would be 100. You'll note that it's AFib because we cannot find a single P wave for each QRS, and my QRSs are randomly occurring. Very clear on AFib. NCLEX, a client has developed atrial fibrillation with a ventricular rate of 150. The nurse should assess the client for which associated signs and symptoms.
Hypotension and dizziness.
Good. Excellent. We're looking for signs of poor perfusion. And if we were to think back to that concept map, neurologically, I would stick dizziness up in that corner box, okay? That's one we didn't mention as we went through. All right, on to coronary artery disease. This is basically reduced blood flow to the muscle of the heart, so the myocardium. There's a variety of arteries and veins that cover the surface of our heart that help to perfuse the muscle. In coronary artery disease, we have atherosclerotic plaques that have, over time, slowly occluded the circulation to these vessels. Over time, it results in a depletion of oxygen getting to these tissues, as well as the nutrients necessary for them to sustain themselves. If you recall atherosclerosis from pathopharmacology, athero, I think one means glue and one means hardening. So we have a hardening of the arteries as well as a plaque that develops. What contributes to these plaques?
Cholesterol.
Cholesterol. And what kind of foods contribute to that?
Saturated and trans fat.
Good, our saturated and our trans fat. So mostly from animal foods and mostly from processed foods that have trans fats, which they're hydrogenated. In addition to that, excess carbohydrate consumption leads to elevated triglycerides, and triglycerides are inflammatory, and they also contribute to atherosclerosis. So it's not just the fat anymore, guys. You also got to watch the excess carbs and sugar. Trivial question for you. Actually, kind of trivial, kind of important. When my heart's beating, when does my heart muscle, in other words, my myocardium, receive the blood? Does it receive it during systole, or does it get the blood that it needs to survive during diastole?
Diastole.
Good. And let me explain to you why. If we look at this slide here, this is my aortic valve. All right. When my heart squeezes blood, it's going to be ejected forcefully above this valve, right? During diastole, the blood falls back and it closes this leaflet here, okay? As this leaflet closes, the backward pressure of the blood sneaks into these coronary sinuses on either side of the aorta and flows down through the entire heart. So our heart muscle does not receive blood during systole like the rest of our body. It receives its blood during the relaxation phase. Theoretically, this is why when you're on the treadmill at the gym, it says to you what your max heart rate is based upon your age. It is possible to have a myocardial infarction from an elevated heart rate. How do you all feel when your heart rate's 180, 190 on the treadmill? Not so great, right? And sometimes for patients who have got some coronary artery disease, you can make their heart rate go so fast that they get chest pain or angina, right? That's because they've exceeded the capacity for the myocardium to receive its blood. This is why filling time is important in two ways. Filling time helps to promote adequate cardiac output so that the ventricles are full, but also the myocardium is getting its blood during diastole. So how long is diastole when my heart rate's 190?
Not very long.
Not very long at all. So that's not much time for that blood to fall back and get into my heart. This is why elevated heart rates are more dangerous for our older population. They have less cardiac reserve. If I'm on a med-surg floor and I can see my telestrips and I walk in the morning and I see someone tacking away in the 120s, the first thing I'm doing is checking my chart to see what my patient's ages are. If they're 35 or 40, I'm not nearly as concerned as if it's an 80-year-old. Does that make sense? So tachycardia can impact the heart in two ways. It can reduce cardiac output because we reduced filling time, but tachycardia can also reduce the body's ability to feed the blood to the heart itself. Everybody got that? Here's another picture kind of giving you a visualization of how the blood flow gets into the heart itself. I need you to know some basic vessels of the heart. I'm not going to make you cardiology nurses today, but I need you to know some basics. Has anybody ever heard of the widowmaker? Which artery on the heart is the widowmaker? It's going to be this red one right here. It's the left anterior descending artery. Okay? It's called the LAD. It's a very common place for occlusions to occur. And depending upon where the clot occurs, depends upon how much heart muscle is lost or damaged. So can you see my mouse here? If I have a thrombotic event all the way up here versus down here, what's the difference in those two heart attacks?
The first one stops perfusion to a lot of the heart, whereas the other one, it's just the bottom.
Exactly. So location has a lot to do with how much damage we cause to the heart. Another common place to get heart attacks is the right coronary artery and sometimes the circumflex, which comes around the back here. Okay. So what I want you to know is the significance of a heart attack. One usually has to do with how fast we got the intervention accomplished. The second is the location of where the clot was. Most heart disease is caused by a slow progression of atherosclerosis that leads to an occlusion to these vessels. It can cause angina. What does angina mean to you, or angina?
Chest pain.
Chest pain.
Good, chest pain. We're going to talk about some different types of angina. They can lead to dysrhythmias, so the ventricles do not squeeze or have a proper conduction. Can result in sudden death. And we'll talk about the different types of tissue damage in relation to the ischemia, or the lack of blood flow. So we'll have 3 different zones for every necrotic, or not necrotic event, I should say decreased event. Assessment of blood flow. You probably have all heard of an EKG or an ECG. If there is a disruption of blood flow, that will show up in the conduction of the heart. We can do exercise stress testing. Has anybody heard of these before? So what do we do in a stress test? What's that require our patient to do?
Treadmill.
Could be on a treadmill, and we're gonna put the treadmill up to a certain pace until the patient hopefully doesn't experience chest pain up until they do. We can also do physiological stress tests. If my patient's not ambulatory, we can take them to a lab and we can induce it with epinephrine or norepinephrine. So that is a catecholamine that will induce the heart rate to be higher. That's called pharmacological stress testing. Any type of nuclear imaging, from a CT scan to an MRI. And what we do most of these days is cardiac catheterization. We can visualize the vessels on the heart through a cath. We could also do a right heart cath or a left heart cath to measure pressures within the atrium and ventricles. So there's a variety of different procedures we can do there. In relation to coronary artery disease, it's usually the cardiac cath that we use to determine the significance of the disease. That is kind of the gold standard. Important concept to remember here. Has anybody heard of collateral circulation before? So over time, if I have been building up plaque anywhere in my body, so remember, atherosclerosis is not restricted to just the heart. It can happen throughout the body. Your body recognizes the decrease in blood flow and starts to create additional channels for the blood to get around it. So kind of think of it like a highway. As the highway gets packed with cars, we start building other roads to get around it, right? That's essentially what your body has done up here. So here's a normal vessel. This one starts to get occluded, and all of a sudden, over the period of years, this collateral circulation forms. I'm sure you've all heard stories of my relative had 90% blockages in 4 of the arteries in the heart, right? And you're probably like, how the hell is that person even alive? It's because they developed collateral circulation. This is also one of the reasons why heart attacks are more dangerous at a young age. So if I have an MI that's at age 40, that's in relation to an embolic event, not a plaque rupture, but a clot that makes its way into my heart. What are my chances of surviving that as opposed to a 70-year-old that's developed this collateral circulation? Does that make sense to everybody? So if I had an MI that occurred right here, this plaque ruptured, and I started to get a clot, some blood flow is still going to make it down. Is it enough? No, but it's some. Does that make sense to everybody? So collateral circulation forms over time. We also know, and this is in a good form of collateral circulation, are high endurance athletes, athletes that compete. They develop additional circulation beyond the traditional that you and I have. So that helps to feed the muscles that they need to perform their particular sport at a higher level than you and I can, because they also develop collateral circulation. So the pathogenesis of CAD, we've got atherosclerosis present, we've got enough plaque built up, an event causes a bit of that plaque to push off or to rupture, which causes my body to want to clot off that exposed tissue. It's in that formation of the platelet plug that causes the obstruction of the blood. Causes of plaque, we talked about these. Hyperlipidemia are triglycerides, phospholipids, and cholesterol. I'm not going to talk more about that. I would like you guys to know some basic numbers for HDL and LDL. You probably learned them in pathway pharmacology. HDL is the good stuff, right? The more HDL we have, the more of a protective effect that it has. We can increase HDL, we know, with exercise. Moderate amounts of alcohol use, which from the science tells us 1 glass of wine or 1 drink a day. LDL has a strong dietary and genetic link. So if you've got a history of high cholesterol in your family, you want to be more mindful of that in your dietary choices. And although you may change your diet, there are some families with strong genetic linkages that still need to take medications to reduce their cholesterol, even with diet changes. I think I've said all this. Here's a table with your values that I'd like you to have somewhat memorized. You may get a test question where I tell you your patient's got a certain level of LDL and HDL as well as overall cholesterol, and I will tell you if they are at risk. I will ask you, are they at higher risk or lower risk for a heart attack? Here's another slide on atherosclerosis.
I have a question.
Sure.
For HDL, can you go back to that slide? So would like 50 be the optimal HDL level? Like what are we looking for? Do we want it to be high because it's good, or?
I have not heard that high can be bad for HDL. That's a great question, Faiza. I would not be able to give you a good answer unless I talk to a cardiologist. I don't know that there's any really bad outcomes for HDL levels that might be above 60. I would imagine at some point it could be an abnormality. It's not good, but I won't give you a bullshit answer.
Thank you, I appreciate that.
Not going to pretend to know everything. But I won't give you a test question that's that difficult, no, either.
When I had my last checkup, my HDL was 66, but provider didn't say anything, so I assume it's okay.
Good to know. Yeah, I'd be a lot more conservative if my LDL was above 190 and things like that. So. This is PathoPharm review for you. I'm not going to get into it. Some definitions you do need to know. Thrombus is a clot. Usually during an MI, there's some type of clot that is formed around that plaque rupture. An embolus is a clot that has broken off from its original location. So a DVT could become a pulmonary embolus. Stenosis, often referred to when we talk about valves. So the valves like the pulmonic valve and the aortic valve are prone to stenosis, a narrowing. And mural is it means the wall. So if we have a mural thrombus, it's a clot in the wall or the vessel or chamber of the heart.
Professor,
Sure.
would the stenosis be caused by the buildup of plaque? Or is it an actual narrowing of the vessel itself?
Great question. That's actually a narrowing of the vessel itself.
Okay.
Stenosis, it's a physiological closing.
Okay.
All right, why don't we take 5 minutes? Does that sound good? We'll come back and we'll blow through cardiovascular arterial disease, coronary artery disease, I should say. Okay? All right, everybody see the screen? Awesome. All right, so coronary artery disease. We know it's strongly related to diet. What type of diet do you think of when you think of someone who's predisposed to getting coronary artery disease or heart attack? What are they eating?
High fat.
A lot of sodium.
Animal
Sodium,
products.
Animal products.
Carbs.
Carbs.
What kind of carbs though? Fruits and vegetables or
Pastas and bread.
Simple carbs.
simple breads, simple carbs, exactly. So the processed foods, all those foods in the middle of the grocery store, all those boxed foods, fast food's high in carbs and fat, and not the good kind of fat because it's fried. Usually low in fiber. And when people eat that kind of diet, they usually also, what's their lifestyle like?
Sedentary.
Tend to be more sedentary, excellent. So not lacking in exercise. Interestingly enough, the shape of your body type's actually related to heart attacks. So for those of you that hold your weight on your hips, you're less likely to have a heart attack as opposed to the male with the giant beer belly. Okay, that puts a lot more pressure on the organs and is associated with higher levels of cholesterol, which can form more atherosclerosis in the heart. Metabolic syndrome, sometimes called prediabetes. Anybody heard of this particular disorder? This is someone who is obese, has a impaired glucose metabolism. We know that's associated with CAD. Women who are have premature menopause or oral contraceptives or on hormone replacement therapies are more prone to heart attacks. And one of the newer levels that we're starting to look at is this homeocysteine. We know that these levels are associated with an increased risk for coronary artery disease. Some terms that we need to be aware of, and I will give you test questions on these for sure. Angina simply means that we have poor perfusion to a portion of the heart, which is resulting in chest pain. There are different types of angina. You could probably all hear about it in the wintertime. An older gentleman or female goes out and shovels their driveway. They get chest pain, they sit down, and then they're fine. That is stable angina. So it occurs with exertion or stress, but when the stress goes away, the pain goes away. Variant or vasospastic angina is not as common, but it is very dangerous because it's a spasm of the coronary artery. It's not related to plaque. If the coronary artery spasms, we're not going to have good blood flow to the myocardium below it. If you'd like, you can easily YouTube a video on this. You can look at it under fluoroscopy. That'll show you a coronary artery spasm, and you'll be able to visualize how poor that blood flow would be. Not nearly as common. Unstable angina. Unstable angina is predictive of an onset of a MI. If you have a patient with stable versus unstable, you know that the unstable is going to be more at risk for a plaque rupture. And I'll show you a picture here in a minute. So unstable angina, symptoms at rest lasting more than 20 minutes. Okay, so they may have exerted themselves, but after they've exerted themselves, it's still present, or it's present at rest to begin with. Not super common, but it can occur. There are certain diabetics that have been so poorly controlled that they are unable to feel a heart attack. You probably heard about diabetic neuropathy. We usually think about it in their feet and their fingers, but you can have such significant neuropathy from diabetes that you're unable to have a sensation of the loss of blood flow to the heart. That would be silent myocardial ischemia. Acute MIs can be STEMIs or non-STEMIs. We'll talk about that in a few minutes here. But I definitely want you to differentiate between stable and unstable angina. If I were to look at the cross-section of a coronary artery, this is what, one second. This is what stable angina looks like. You can see that we've got atherosclerosis and plaque here, but we've still got blood flow. Everybody see that? In unstable angina, we've got blood flow, plus we've got some platelets starting to lay themselves down here. So you can see we've moved one step closer to developing a thrombus and a heart attack. Everybody see that visualization there? Plaque rupture. Anybody heard of the Monday morning heart attack? They are a real thing. It doesn't always have to happen on Monday, but we know that Mondays are more stressful than Fridays for us, right? So upon arising, there is a stress that activates the sympathetic nervous system. It causes an elevation of blood pressure, heart rate, and contraction. That event can cause the plaque to rupture, resulting in a subsequent MI. They're frequently upon the first hour of rising. We're about ready to do something in about a month when we go back to daylight savings time. So there are more heart attacks at the change of the clocks than any other day of the year. One more reason not to do it. That we have more of them during spring forward because we lose an hour of sleep. So more heart attacks on spring forward than any other day of the year. I need you to know these three different zones. We are hoping when someone has a heart attack that the patient only has ischemia. If they only have ischemia, the full function of the heart may return over time. If they've got injury, there may be permanent damage to the contractility of that heart muscle. And if they've got necrosis or an infarct, then it's dead and it will never come back. Along with the infarction and the dead cells, the fact that you have two problems. One is that the heart does no longer function, but also that necrosis results in toxic metabolites that are released from the cells, which can put further stress on the heart itself. So three areas. Ischemia is the best one. Injury, some recovery, and what we don't want to have is a true infarct. Anybody heard the phrase, time is muscle? So the faster we can respond to an MI, the greater the chance that we have ischemia or just injury.
How much time, like in general, does like someone have from the cell to become necrotic? Is it like over a few hours or over like a few days?
It really has to do with the location of the MI, the significance or the amount of collateral circulation they have. But if you get to the ED, every emergency department, and actually if you work in a hospital too, we have parameters on how fast someone is supposed to get an EKG, how fast that should be read, and how quickly they need to get to the cath lab if they have ST elevation. Great question. I'll tell you a story in a few minutes about one. All right, so pathological changes. Ischemic areas cease to function within minutes of the occlusion. irreversible damage can occur as soon as within 20 to 40 minutes. If early reperfusion occurs at the onset of ischemia, we can prevent necrosis and injury from happening to begin with. And as I said to you, Sarah, it depends upon location, how extensive the occlusion is, and how much heart tissue is distal to that occlusion, and obviously the metabolic function of the heart during that time. And obviously, as we know, collateral circulation develops over time. So if someone has had the chance to develop that collateral circulation, they're more likely to have some blood flow to that tissue. All right, so chronic heart disease is significant with stable angina and variant and sometimes silent. And then over here, acute coronary syndrome, strongly related to unstable angina. That's that formation of that clot in the plaque. And we're going to go through these here now. So if someone's experiencing chest pain, I want you to think of PQRS&T. Have you ever heard of that acronym before? So PQRS and T are correlated with the conduction of the heart. So P, what provoked it? So if I have a patient who's presenting with chest pain, I might ask them, do you have pain when you're coughing? If it's coughing or with deep breathing, it could be pleuritic pain. But if they have pain that started, let's say they went up and down a flight of stairs, that would be concerning, right? That sounds more like it's heart related. Even more concerning than that, do you have pain at rest? Now we're really concerned. Okay. What's the quality? What qualities do you associate with heart attacks?
Someone sitting on the chest.
Good. So a lot of pressure on the chest. Excellent.
Sharp.
Good. Sharp. Stabbing. Where does it usually radiate to?
Left arm.
Arm and jaw.
Good. Left arm and jaw. Excellent. Good. Severity, and that's going to be, patient determined. Could be quite severe or mild. And then the timing. So did it happen upon arising? Did it happen after a certain event? Did it happen after stress? Those are all questions we want to ask. I talked about angina with stress, relief of minutes by rest. What is NTG, by the way?
Nitroglycerin.
Good, nitroglycerin. So our patients who've got stable angina, they may have a bottle of nitroglycerin at home. And they'll have instructions from their doctor that if they're experiencing stable angina to take nitroglycerin. There'll be a quiz question coming up on your Bruner and Suddarth quiz that you have for this Sunday around nitroglycerin. So if I take it 3 times and pain is not relieved after I've taken 3 doses of it, I need to call
911.
911. Good. And we know that angina that occurs with rest or is of new onset and increasing intensity is at an increased risk for having an MI. Here's an additional slide here describing stable angina to you. I'm not going to go through them again because I've already talked about it, but I have them here for study slides. A patient is comfortable at rest, but typically experiences angina when walking up more than 1 flight of stairs. This is an example of what?
Stable.
Good, that is stable angina. Excellent. All right, let's move on to acute coronary syndrome, and we're going to talk about ST elevation. So the ST segment is an important part of the strip to look at in your patients who may be suspected of having a heart attack. If it's elevated or even depressed, it may indicate that your patient has had significant disruption to the tissues of the heart, which is affecting the conduction. It does not always show up right away, but when it does, if they've got ST elevation, they are immediately a candidate for the cath lab. Everybody understand that? So an ST segment MI, called a STEMI, if they're not at a hospital with a cath center, they will be quickly. So Union Memorial has a cath lab, but Good Sam does not. So I get transfers from Good Sam all the time because they need to go to our cath lab and get treated for this heart attack. Here's another picture of what the elevation looks like. Here would be the normal ST segment, and here's ST elevation. You can see that the QRS does not come back down to the isometric line and stays elevated. A non-STEMI, in other words, a patient who's got a heart attack but does not have ST elevation, still needs treatment, but will not likely go to the cath lab as quickly as someone with ST elevation. And I'll talk about that treatment here in a little bit. They still have some blood flow down below that occlusion, but not enough. So if I were to look at the pathophysiology of these two heart attacks, here is your ST elevation. What do you notice as the difference between an ST elevation and a non-ST elevation?
One is completely occluded and the other has a little bit of blood flow. And
Exactly.
the thrombus is smaller in one versus the other.
Excellent. So your ST elevation, as you can see here, almost no blood flow is getting down through that coronary artery. Someone experiencing a non-ST elevation still has some blood flow. Okay? They're still going to exhibit some signs and symptoms of a heart attack, but we still at least have some blood flow. Within these types of heart attacks, the LAD, as you can see, is 40 to 50% of the time. The right circumflex artery and the left circumflex arteries are the other two most common. So diagnosis of CAD and MIs. So this is probably most strongly related to just someone having coronary disease. We'll look at a good history, identification of risk factors. So that's obviously diet, lifestyle, cholesterol panel, looking at their genetic history. We always want to rule out other causes. Oftentimes, acid reflux and GERD can be associated with symptoms similar to a heart attack, so you want to rule those out. And we usually rule out the heart attack first. And we'll do that with a series of labs and tests. Get an EKG. If it all comes back normal, then we start to be a little less concerned. However, if we see that ST elevation, we're going to move quickly. We're going to look at myocardial markers. And what is the most common lab that we look at today to determine whether or not someone's having a heart attack?
Troponin.
Good. Grab those troponins. If we see elevated troponin levels, we know we've most likely got some heart damage. If EKG is still normal, troponins are normal, we could do stress testing, which could be exercise-based or pharmacological-based. But if we've got an abnormal EKG and we've got a positive troponin, your patient's most likely going to the cath lab. But you understand that pathway? All right, so some classic signs of an MI. Abrupt onset or progression of unstable. Pain, severe crushing on the chest, can radiate to the left arm or the jaw. It's prolonged and not relieved by rest or nitroglycerin. Your patient may also have an elevated heart rate and respiration rate. They could be cool and clammy and have diaphoresis. Here are some additional changes that you might see in a heart attack. You can have the ST elevation, which I've mentioned. A T wave could be inverted. I'm not going to give you lots of detailed test questions about this. Again, I'm more focused on the treatment, but I want you to know that these are changes that you may see, and they may stay changed for some time after the heart attack, depending upon what restores itself. Whenever I look at telestrips or EKGs, I always like to compare it to a previous strip to see if it's new or if it's already been existing. New changes are always of great concern. Abnormalities that were there upon admission or a few days ago aren't nearly as concerning. Does that make sense to everybody? So if you see an abnormality in your telestrip, best thing to do is compare it to the prior one and look at the entire stay. And if in doubt, grab an EKG. Troponins. So the reason we look at troponins, and this goes way back to anatomy and physiology for you a long time ago, we have troponins in every one of our muscles, and it has to do with the cross bridge. When the heart muscle becomes damaged, troponins are released from this area right here, and they may stay elevated for some time. When I draw a troponin in a hospital, we usually will keep drawing them until we find out when they have peaked. Once we see that they're starting to fall, we'll usually stop drawing them. So we call them serial markers. So you're going to get in order to keep drawing troponins until they have peaked. Depending upon how your patient's heart attack is being treated and the severity of it will dictate how quickly they fall. It may be elevated for some days. Our goals in treatment of a heart attack is to prevent or minimize infarction. Remember, we're trying to just have an area that does not have injury or necrosis. We want to make sure we increase the oxygen supply of the myocardium. Decrease the metabolic demands. What does that mean? If I say decrease metabolic demands of the heart, what do I want to do to my patient?
On oxygen?
Get them on oxygen, let them rest, and also give some medications that will decrease the contractility of the heart. We'll talk about those a little bit. And obviously symptom relief. Patient's going to be anxious, they're going to be in pain. So a summary, we've got acute oxygen depletion, which is causing the issue with the pain and the heart attack. Prolonged ischemia can lead to necrosis. We've got 3 zones, the ischemia, injury, and infarction. And here I have the T waves associated with the ischemia, ST elevation with injury, and Q wave is associated with an infarction. Risk factors for a MI. We've talked about diet and lifestyle. Obesity, which we didn't mention too much there. Stress can also cause it. Non-modifiable, obviously things like age, gender, family history, and ethnicity are not modifiable. So what is this patient exhibiting here? Is called Levine sign. Has anybody heard of Levine sign before? This is when you'll have a patient experiencing a heart attack that's just kind of holding their chest. That's indicative of the pain associated with an MI. Substernal pressure and radiation. They may have the shortness of breath and diaphoresis. So make sure we do an assessment on women separately. So women can present exactly like men. However, women oftentimes present differently. So you want to ask additional questions of women to suspect an MI. Oftentimes it's general nausea or epigastric pain. They may have a general level of fatigue, especially in the shoulders and upper arms. And women are more likely to have silent heart attacks than men. Men have more heart attacks than women. However, women are twice as likely to die from an MI than a man. We figured that stat out. So men have more heart attacks than women. But if you're a woman that has a heart attack, you're twice as likely to die from it than a male. And I suspect it probably has a lot to do with the fact that they can present differently than men. Here are your labs, EKG. I'm not going to make you guys memorize myoglobin and CKMBs anymore because over the last 2 or 3 years, we really don't draw them anymore. Whenever I'm working with patients with heart attacks, it's almost always troponins these days. So you may see them occasionally, but troponin's really your gold standard for labs now. Everybody got that? So nursing diagnoses for a patient with heart attacks, obviously acute pain, ineffective tissue perfusion, mostly related to the myocardium. They could have an activity intolerance and obviously a lot of fear and anxiety. So what do we do for a patient who's either having a heart attack in the ED or having a heart attack on your floor? Has anybody heard of MONA before?
Yes.
I want you guys to always remember MONA. Morphine. Morphine does 2 things. Reduces pain, obviously. Actually, kind of does 3 things. Also relieves some anxiety. And it also dilates the coronary arteries. So I'm going to give my patient morphine. I'm also going to apply oxygen, even if they're satting 98%. I want to get as much oxygen to that heart as possible. So put on the oxygen. Nitrates, that's your nitroglycerin, right? You're probably going to give it sublingual. That will help to dilate the coronary arteries. So even if there is a thrombus there, we can expand that vessel to allow some blood to get around it. And lastly, we're going to have them chew that aspirin. So if they're just having a non-ST elevation, they'll be less likely to have that clot get bigger. Okay, regardless, I don't care if it's ST or non-ST, we're giving them aspirin. Okay. If they are determined to have ST elevation and a positive troponin, they are headed straight to the cath lab. If it's the middle of the night, we're calling the cath lab team in, and they're supposed to be there within 45 minutes, ready to go. Okay, this will be a quick whisking off for an intervention. I'll give you my own personal story. So I think it's almost 6 or 7 years ago now. My father had an MI. I was a nurse, I think only for a couple of years. He called me in the morning and said, had some chest pain while I was doing some work around the house. I gave him the usual questions about it. And I said, did it go away? He said, yeah. He had never had any cardiovascular history significant before this. He did have elevated cholesterol for years, and he had taken a statin here or there. Later on during my shift, he called me and said, I got some chest pain while I'm sitting here on the couch. I said, time to go to the ED. I'm not sure if anybody knows the Bel Air area, but they live near Upper Chesapeake, literally like 2 traffic lights away. So my mom drove him to Upper Chesapeake. I guess this was around 5:30 or 6 o'clock at night. By the time my mom had parked the car, my dad had had Mona. EKG was done, troponins were drawn, and they gave him all of the Mona attributes. By the time my mom called me, he was headed to the cath lab. By the time I left my shift early and left University of Maryland and drove to Bel Air, he was in recovery. So because they acted quickly, and my dad got there quickly, he never had any long-term effects from his heart attack. So he only had injury. And it's because they were able to act quickly and recognize the symptoms and treat it appropriately. So that's about as successful as a story as you get from a heart attack. It was in the LAD. And for about a year or two after that, he attended cardiac rehab. He was on a statin for a while. They put him on an ACE inhibitor, and he was on Plavix for, I think, a year or two. So they stented him. He got 2 stents to keep that artery open. So that is an example of fantastic nursing, fantastic interventions by the cath team and the providers, but also early recognition of what was significant. So as soon as it went from some chest pain while you're doing something to chest pain on the couch, that was time to go. You already had this question today. The question and answer is what?
Iodine.
Iodine, good. All right, I got some pages for you guys to read here about percutaneous interventions. So there are a variety of amazing interventions that we are able to do in the cath lab. They can do balloon angioplasty, which helps to open up the artery and reperfuse the heart. They can place stents in there. They can even do percutaneous revascularization, which sounds really scary. They actually go into the left ventricle and use a laser to allow blood from the left ventricle to penetrate the myocardium and indirectly perfuse the heart that way. It's called revascularization. Anytime you start using a laser inside somebody's heart, you're making the big bucks. Other interventions besides going to the cath lab. Frequently at Union Memorial, I'll get a patient on an IMC that has a non-STEMI. They've got elevated troponins, they're having a heart attack, but they're not going to the cath lab. They're going to come up on a heparin drip. Why do you think that is?
For the clot that's in the vascular system.
Good. Does heparin make the clot go away?
No.
No,
Good.
it just reduces the chances.
Good. So it just reduces the chance of it getting bigger. Excellent. Before we had cath labs, like we're using them in the last 10 or 15 years, a lot of our patients who had heart attacks got thrombolytics like TPA. TPA has a hell of a lot of side effects because it's systemic. So we really don't use TPA systemically for heart attacks anymore because we've got so many more cath labs in the area. GP2A and 3B are other anticoagulants. We may put them on calcium channel blockers to reduce cardiac demand and also reduce afterload. Beta blockers do the same thing. They reduce cardiac contractility, which alleviates the metabolic demands of the heart. We'll frequently use diuretics because during the time the patient was experiencing a heart attack, regardless of whether or not the heart attack was treated appropriately, during a period of time, that heart was not contracting well, which could have caused there to be some fluid retention. So we'll use some diuretics. Dopamine and dobutamine are also vasoactive drugs that help with contractility. Big deal for patients after having an MI is medication compliance. If they weren't already taking medications for cardiovascular disease, they're going to be given quite a few new medications to take for a period of time afterwards. So you want to make sure that they adhere to those. The medications that we prescribe have been scientifically proven to reduce the incidence of second heart attacks afterwards. So things like Plavix and ACE inhibitors and statins have all been shown to reduce the incidence or frequency of second heart attacks. Patients need to take them regardless of how they feel. We've all had times where we take antibiotics until we feel better and then we forget to finish the dose, right? So make sure your patients are taking this regardless of how they feel. And explain to them, these medications are to prevent a subsequent heart attack from happening. We want to control their comorbidities like hypertension, diabetes, their high cholesterol, and help them to lose weight. If they're not exercising, they need to start an exercise program under the consultation of their doctor. So cardiac rehab is basically going to the gym with a heart monitor on. So they're going to be watched carefully. Stop smoking if they haven't already done so. Look at dietary counseling and other integrated medicines to treat the stress levels that the patient may be experiencing. How are we doing? We're out of time. Is this interesting to you? Is it conceptually hard for you? What is it? How is it? How are you feeling about the content?
Yeah, both.
Okay.
Some of it's what we did at the end of Patho last year. So I realized like I had a lot more notes and already like key ideas to help me remember stuff about perfusion.
Good. All right, so next week we'll pick off where we left here. We'll start talking about cabbages and then we'll get into all the other disorders.
I have a question.
Sure, shoot.
So our quiz on Wednesday is supposed to be on urinary disorders and perfusion. Are we still going to focus on that?
So your quiz next week will have fluid and electrolyte questions. It'll have questions on labs. It'll have some questions on renal content. Not so much on perfusion. It might have some questions on what we covered thus far, but I won't give you questions further into the content that I haven't covered yet. But study mostly your fluid and electrolytes. There'll be, I guarantee you, I want you to know the BMP, I want you to know the CBC. You should know mag, phos, and calcium. And then your urinary elimination lecture.
Do we get a blueprint for the quiz or just the exams?
Just exams. My quizzes are too small to do that with. It's only like 20 questions.
Okay.
But if you focus on the slides and everything I've said and the Kahoot questions and the past classes, you will do just fine.
Professor?
Yes.
I know we have a quiz this Sunday for the book,
Yes.
but I don't know if you worked on opening that.
I did
couldn't
open it
see the-
yesterday. Have you tried recently?
No, I just didn't know. I didn't
Yep.
get a. It's open.
I
Okay.
finished it. Yeah, I finished it at school yesterday after I finished the Sims. So it should be up. It's 25 questions, unlimited time. They are questions that I have gone through the test bank for to find. So they should be pointed and helpful.
Thank you. Also, is there anything that you would like us to do that is not on the calendar? Like, I know last week we did a pre-sim, but for those that are going to clinical, we don't have to do anything like that?
Yeah, so I don't put those on the calendar all the time because it depends upon when you come to sim. So for the students that went to clinical this week, you need to do the pre-sim worksheet from Perfusion and read the article on compassion that says week 2 and 3, and then you'll be prepared. For those of you going to clinical, there's nothing to do other than to get some rest, get a good breakfast, and have fun at clinical. Any other questions? All right. You have research this afternoon? All right. Get outside, stretch, and get some sunlight before you got to sit down again.
I forgot I do have another question.
All right.
Thank you.
Email me or text me with questions.
Thank you.
You're welcome.
Thank you.
Thank you.
Thank you.